Outside of there.
Okay, there we go.
Oh, really? Oh,
All right.
Yeah.
All right, we're gonna go ahead and get started. It's 8. Thanks for coming this morning to our comparative ocular pathology rounds. I'm Dr. Jamie Miller, and I'm gonna kick us off today. The first case that I've got for you is the right eye from a 14-year-old female spayed basset hound mixed breed dog. It comes with a history of buphthalmia, diffuse corneal edema, fibrosis, and stromal vascularization. The dog did have a history of a gentamicin ciliary body ablation procedure in May of this year that was unsuccessful at controlling the intraocular pressure. They noted the intraocular pressure was 50, and they said yes to glaucoma. It's been going on about 3 months. And they also note that they had previously identified a tan-colored irregular thickening of the iris ventrally prior to giving the ciliary body injection. So this is what the hemisection of our globe looked like. It was buphthalmic as I described clinically. Here we've got the cornea up here. We can see our iris leaflets here and our ciliary body are very thick and very brown, very mass-like. Our lens is posteriorly displaced and kind of displaced by the mass. Vitreous is a little bit cloudy. Retina is partially sort of detached. And we can't really tell what the optic nerve head is doing because of this detachment. So let's look at what we got histologically here. Start with the subgross as best as I can here. Again, it's a big eye. Got cornea up here at the top, a little bit cellular here. Here's our thickened iris and ciliary body with a lot more cellular infiltrate in there and a lot of pigment as well. Our lens, our retina, you can see was detached, some membranes coming off of it. There is.
See. Go ahead.
Our optic
Except
nerve.
that the voice is a little faint, so I'm it's not what I want. It's the opposite of what I want. Can you press escape there?
Yes. I did.
You did?
I did.
Okay. All right, keep going. I'll
Okay.
be working on the background.
Ignore the wizard behind the curtain, sort of thing. All right. Let me get us back towards the front of the globe here. Focus here. So here is our.
Sorry, guys.
Want me just to pause for a minute?
Can you say something?
Hello.
1, 2, 3.
1, 2, 3.
Testing.
Hello, hello.
You gotta sound professional.
I'm sorry.
All right. Well, is it still faint? Can you guys hear us?
Okay.
Okay, they can hear us fine.
Okay.
All right.
We get rid of that.
No.
Click the far left, yeah.
Monday. Wednesday. That's the day. Okay. Go. All right. Put a little pointer here in the middle. Okay, so we have this mass that's unencapsulated here, expanding and effacing our iris and our ciliary body. It is partially pigmented, a little bit necrotic. Kind of creeps into the limbal sclera, maybe peripheral cornea here. There's a lot of pigmented cells floating around the anterior chamber with some hemorrhage, probably some fibrin, some acicular cholesterol clefts, so probably more necrosis and cellular debris. And we come in and look at the cellular infiltrate here. We can see, again, a partially pigmented population of what are neoplastic cells. A lot of them are polygonal, but there's also some that are spindle cell in here. closer. It's nice to look at these not so pigmented neoplastic cells to get a good look at the nuclear features, because in these big polygonal ones, it's often obscured by all the pigment. And so the nuclei are kind of round oval, finely stippled chromatin, maybe indistinct to one nucleolus. And there are mitotic figures around. Let's see if I can find some good ones. Maybe some here, some here. Ooh, here's a good one down here in the corner. Stick that sort of towards the center. And so as we scroll around, we can see that there's a lot more mitotic figures, pretty mitotically active. I think I got a mitotic count of like 12 when I did this. So that pushes this over into a malignant pigmented tumor, so a malignant melanoma in the uvea tract here. And then to sort of go over the other changes here in the globe, the cornea, the corneal epithelium is a little bit thickened, a little bit hyperplastic. If I can get it in focus for you so you can believe me. We've got some neutrophils and blood vessels coming in, so some vascularization and inflammation here. We've got a lovely retrocorneal membrane of all this collagen and all these pigmented cells lining the back of the cornea. And we can see the mass sort of effaces the trabecular meshwork and the iridocorneal angle. Again, we've got some intraocular hemorrhage. The lens did have some cataractus change. So a little bit closer here. We can see closer. The lens epithelium has migrated towards the posterior portion of the capsule. So that's posterior migration of the lens epithelium. And we have these degenerate lens fibers. So we got these big pools of liquefied lens fibers, more ganglion globules, because they don't have any nuclei left in them. And so a nice cataract formation here. And again, more cellular and pigmented debris in the vitreous. And our retina is detached and a little bit atrophied. We don't have any more ganglion cell left, and our layers are kind of jumbled up here. So we have retinal atrophy, detachment. There's also a little bit of hemorrhage and like a fibrovascular membrane with a lot of pigmented cells kind of extending off into the vitreous. Kind of secondary changes here. Our optic nerve head, we couldn't see it grossly, but we can tell that it's a little bit cupped here. And there's a lot of hemorrhage and gliosis and stuff going on in the optic nerve. So consistent, probably with glaucoma. All right. So this was interesting case. Just because we had a malignant melanoma here. Sometimes we will designate it as a ring when it's a little bit more circumferential and effaces more of the eye than just kind of focal. And the interesting part was the gentamicin ciliary body ablation that they were using to try to help control the glaucoma. We've got some cases where there is like that we usually get a primary intraocular tumor diagnosed in eyes that have a history of gentamicin ablation. Sometimes it's because that a lot of times the mass is there and they might not notice it, which was not the case in this one. They saw it before they did the ablation, and it's thought that the gentamicin kind of affects the tumor that's already there and may make it more malignant than it might have already been. So just something to consider if you're thinking about doing a gentamicin ciliary body ablation.
The phenomenon we officially call poking the bear.
Poking the bear.
So yeah, just to be clear, which is something that comes up every time we have cases like that. We don't think that gentamicin caused the neoplasm from scratch. It's usually an unidentified tumor, as Jamie was saying, that receives a gentamicin injection, and gentamicin is cytotoxic. That's the whole reason for doing the gentamicin injection, is to cause chemical ablation of the ciliary body epithelium. And I think that often benign neoplastic cells really don't like that. And so we have seen versions, kind of atypical versions, atypical malignant versions of benign tumors in these cases. More commonly in unrecognized iridociliary adenoma that presents more malignant features, melanocytic tumors like that. So, yeah, that's mainly it. And another comment about the definitions as a ring malignant melanoma. That's basically something we do for our database and entertainment. And one day that might come up and be project related to that. It's just a designation of a more diffuse tumor that circumferentially affects the iris, kind of like a feline diffuse iris melanoma in a cat. It's a term that's directly borrowed from the human literature. But as far as we know, there's no prognostic feature significance in calling a tumor a ring melanoma versus still regular malignant melanoma.
What were the cells lining the surrounding the optic nerve? Was that just meninges or was that tumor?
It was just meninges. The tumor was completely excised.
But Dr. DeBilzig is hard at work as we speak here. He just sent a text. If you guys haven't seen on the chat, that 20 out of the 25 melanomas with gentamicin injections in their database are malignant. So, poking the bear.
All right. Next up, there's the right eye from a 16-year-old exotic short hair cat. With the clinical history of a fleshy proliferative growth on or in the cornea of the right eye that increased in size following topical tacrolimus that they were using for 1 week. After treatment with topical steroids for 1 week, that was also following the tacrolimus. The eye broke out with multiple corneal ulcerations and profuse mucoid discharge. Plus the growth of said mass did not significantly change in size. So they discussed their options and the owner elected a nucleation. They said no to glaucoma, said the other eye was normal. They did note that the cat does probably have GI lymphoma, that there were multiple intestinal masses observed on a recent ultrasound of the abdomen, but no biopsies were performed, and it's on systemic prednisone palliatively. It's also got systemic hypertension and is being treated with amlodipine, and it has persistent proteinuria. Lots of things going on with this kitty cat. So grossly, this is a front-on view of the cornea here in the globe. We can see that about half is this kind of opaque tan tissue. It wasn't a distinct mass per se, but kind of like a thickening that we can see on the cut section here is kind of thick. And then the rest of the globe was not too bad. The vitreous was a little thin. But I'm going to take a look at what's going on in the cornea. All right. So cornea up here at the top, we can see it's pretty hypercellular here, lots of extra cells there. Here's our iris leaflets, lens, and as we head towards back, you notice that there's actually pretty marked cupping of the optic nerve head, which is not normal in cats. Usually we associate that with glaucoma, which they said no to. So we will look at that a little bit more closely. Right. Oh my goodness, it's pretty dirty. Maybe a little bit scratched. All right, so if we start out here in the periphery of the cornea, We can see that the corneal epithelium is quite attenuated. It's very thin. It's maybe down to one layer. We do have neutrophils and blood vessels coursing in. And as we head towards the axial cornea, we lose the corneal epithelium. And as we keep heading towards where it was much more cellular, again, we don't have any more corneal epithelium, and there's a lot of neutrophils in here, lots of blood vessels. There's a little bit extra clear space in here, so there's probably some edema. I'm starting to get more, probably some fibroplasia and lymphocytes, plasma cells in here. And as we were looking at this, we did come across a little island of epithelial cells in the stroma here, probably corneal epithelium. We were like, that's interesting. So we didn't see a mass per se, but we could see how this could form a mass effect on the cornea. And we were looking at those epithelial cells, and we decided to get some more sections to see if we could find any more of them. And we'll talk about that in a minute. I'm going to finish up here. As we head back, our angles, trabecular meshwork are pretty open, a little bit inflamed. Got a little bit of lymphoplasmacytic anterior uveitis. And a little pre-iter fibrovascular membrane coursing along the front of the iris there. Kind of all probably secondary changes to the corneal ulceration. And then again, surprising since they said no glaucoma, and we don't often see this large cupping in cats, even when there is glaucoma. And so there's a big atrophy and loss there. And we can see that there's no retinal ganglion cells here either, which is a little bit more common with feline glaucoma. It's usually just mostly what we see is loss of the ganglion cells, maybe a little bit of cupping. Here on the dorsal side, it's a little bit spared because they're still here. So we also have to answer what is causing the glaucoma question in this cat. Let's see. And there's a little bit of fibrin and hemorrhage in the anterior chamber here, so a little bit hypopion. So thinking about the glaucoma question and having quite open angles in a cat, we were starting to look at the venous plexus vessels, and we noticed a couple are starting to get surrounded by these spindle cells separated by this kind of clear to myxomatous matrix, maybe a little few inflammatory cells. So we got extra sections to kind of look for more corneal disease and to take a look at more of those blood vessels.
Then they give you a systemic blood pressure.
They did not. They just said systemic hypertension and on amlodipine. So here's a little bit more of the corneal disease. And again, these epithelial cells were just kind of scattered, very rare, maybe even necrotic starting to look, and lots of edema, lots of inflammation and stuff here as well. So again, no specific mass, no tumor, but definitely a mass effect for what's going on in the cornea. And then it was actually, we actually trimmed in the other half of this globe. So again, more corneal disease, a little bit more stuff that looks a little bit more like granulation tissue. But this one had a lot better stuff around our outflow tracks here. And so we see this material in feline open angle glaucomas. And so I think that's what was going on in this case, is that the cat has primary open angle glaucoma based on this stuff. Even though they said no glaucoma clinically, we definitely have glaucomatous changes in the retina and the optic nerve. And then all the corneal stroma stuff, probably edema and secondary changes from probably buphthalamus. And we wondered if with the presence of the epithelial cells in there, if there was like collagenylysis and other potential, maybe even corneal hydrops previously in this case. Usually with corneal hydrops, we like to see like breaks in Descemet's and separation of Descemet's membrane from the corneal stroma, which we did not see in this case. But we do have cases where animals getting like systemic prednisone and stuff like that were affected with corneal hydrops, which this cat definitely had a lot of systemic with the thoughts of GI lymphoma and having treatment like that. So yeah, feline open angle glaucoma, having that stuff around the vessels in the outflow tracts there, and a severe ulcerative, probably collagen-lytic keratitis with epithelial attenuation, which we often will see with feline herpes virus. So maybe that was also playing a role in the corneal disease. And then secondary changes, some of that hypopyon in the anterior chamber and a little anterior uveitis to go along with that. So
Yeah, those epithelial cells in the stroma were interesting. Kind of an unusual finding. I think if there was collagen-lytic keratitis, it was gone by now, right? Because there's basically the opposite now. It's a granulation tissue.
right.
So I don't know how to consider that presence of those cells deep in the stroma and what we're seeing now. So yeah, I think it could be that there was collagen-lytic process at some point and the cells just got stuck there. But yeah, cool.
Are we sure they're epithelia and not some hypertrophic wonky endothelia?
Yeah, I think so.
I just glanced at them, so
Yeah.
I mean, it
There
sounds
were-
like you guys spent more time on
There
this.
were a few that
Yeah.
looked very keratinized.
Okay, okay.
Yeah.
Yeah, and large, but yeah, that would definitely be differential. And who knows? It's a cat. Attenuated corneal epithelium, so there's potentially herpes virus at some point and try to blame everything on herpes virus.
Blame the herpes virus.
So what would your differential be for that gross appearance? Obviously, this is granulation tissue. For those of us in the room that would be like, no, I don't expect a corneal granulation tissue to be my primary process here.
Neoplastic.
Hmm?
There could be a couple of neoplastic differentials for a corneal steps taking a peek.
So yes.
Lymphoma,
Are you asking the
sarcoma.
room for, or like, are you
Oh, sorry,
asking your
yes.
students?
Yeah, no, I'm okay with whoever.
Okay.
Because I just want everybody to kind of think about that. They're gonna be seeing it.
Right.
So if I look at that, I mean, that's not gonna be the top of my list, it's gonna be granulation tissue.
Right, yeah, it was a little odd, which is why I brought it, Mass Effect, for the granulation tissue, lymphoma, squamous cell carcinoma for sure,
Granulomatous keratitis. something. Yeah, it's very non-specific.
yeah, the conjunctival surface,
Mhm.
carcinoma.
Schmee.
Right, yeah, depends on where it's coming from.
No, I know. All right,
Thank you.
cool, you're welcome. All right, next up's Dr. Megan Clement.
Where you start, you'll diaphragm on the bottom.
I could close it all the way. That could be fun.
Keep seeing it, I'm gonna look at it.
All right. The next case is unfortunate that it's not the next case, given our discussion just now, but well, we'll have to wait now. So the next case is 13-year-old neutered male domestic short-haired cat. Presented with anterior uveitis in February of 2023 and a secondary glaucoma at that time. It was controlled by March of 2023, developed corneal bullae/inclusion, cyst/blindness on July of 2024. So kind of an ongoing apparent uveitis in this patient and some corneal disease. It's worth noting that this patient is also FIV positive. On our gross exam, so this is the other half of the globe, went back to take a picture later because things happened when we looked at it. So we do have this kind of thickened and cloudy cornea, and in particular, there was this area of notable thickening and opacity right here. So we'll take a look at that histologically in particular. The globe is basically full of this viscous, cloudy fluid, just more viscous throughout all the chambers than you would expect, and probably too liquidy in the vitreous and too thick in the anterior chamber, essentially. And then little bits of blood here and there. And then the other thing that I'll really point out is that this retina is detached, and it also looks kind of funny. Basically, it's surrounded by this halo of tan tissue with the retina kind of in the middle, looking a little bit thickened. So that's our gross view. F11. I'm going to go straight to the low magnification view. We definitely have too many cells kind of carpeting our uveal surfaces, free floating in our chambers here, mixed with blood. So too many cells, lots of purple. We'll quickly head to the cornea, where there's something quite unusual going on. There's this vast expanse of empty pink surrounded by way too many cells again. We'll come back to that. Again, really inflamed looking uvea. And then back here, we have cells essentially carpeting the epichoroidal surface and basically carpeting the retinal surfaces, as well as multifocally invading the retina itself. So when I look at this posterior segment from really low magnification like this, it actually puts me in mind of fungal disease, because oftentimes that'll present mostly in the posterior segment, often kind of subretinal and carpeting epichoroidal surfaces. So I was all like, it looks like we might have some infectious disease here. However, you zoom in on these guys. They're round cells, and sometimes they kind of look mixed morphology from low magnification. But as you look around at them, they actually start to look quite ugly, and many of them are binucleate or multinucleate. They have an open chromatin pattern, often with distinct nucleoli. We can keep looking around and prove to you who this population is. We find a better area. There we go. And some significant variability in the nuclear size and shape. And again, many of these multinucleate cells around. So these are actually starting to look quite neoplastic. And what really clinches it is looking at that cornea, which I saved for last because that's my favorite, saving the best thing for last. Makes total sense when you're doing pathology. Trust me, it doesn't. Anyway, so here they are forming sheets in the corneal stroma. And especially up here in the corneal stroma, they have a very particular morphology where these cells have eccentrically located nuclei and a perinuclear clear zone. They're looking rather plasmacytoid up here. So we have a round cell population with sort of plasmacytoid features and frequent multinucleate cells. And just to show off that this swath of empty pink area in between these neoplastic cells, we'll go ahead and call them neoplastic at this point, is occupied by eosinophilic cellular necrotic debris and maybe bits of karyorectic debris here and there, just necrotic tumor, basically. So we did some IHC on this case. And I will show you this one first.
Kind of spaced out during the history. Did they say anything?
They thought it was anterior uveitis, which it was. There was also anterior uveitis. It's another one of these cases, which is frustrating. The cornea folded on itself quite a bit, unfortunately, but we do still have some really good
What is that?
findings. This is MUM1. I probably didn't say until now.
For the gentle folk.
Indeed. So these round cells, the vast majority of them, not all of them, but the vast majority, have a strong positive labeling in the nucleus, which is where MUM1 should label.
Go higher.
Yeah, there are probably better areas, but there is a giant multinucleate cell sitting right in here, so it's not bad. And especially the multinucleate cells having MUM1 labeling is pretty proof positive. Interestingly, so we also did a CD3, CD20 because we've had some weird like plasmablastic lymphomas that have looked funky like this.
The corner one staying.
They did, but it all folded up and it's not as pretty up there.
Never mind.
I can show you the edges
No,
though.
don't worry.
You can still see it at the edges. Wait for it. Here we go. Right?
Let's see between the.
Yes, between the cracks. They're still positive. It's just not very pretty up here. I know, so sad. We could redo it. I mean, if it was like a published thing, it would definitely be redone, but it's diagnostic as it is, so I moved on to other cases. This actually I shouldn't even bother putting this up. The CD20 was negative and the CD3 was kind of interesting in that in the cornea. So there's lots of non-neoplastic lymphocytes that are picking up both CD3 and CD20 admixed with the neoplastic cells, but with the CD3 at least, the corneal and neoplastic cells were actually kind of convincingly positive in some areas. So like here, these sort of larger cells that don't really look like normal non-neoplastic T lymphocytes, I was reasonably convinced of some degree of positivity here. And I think that this is either going to be some sort of aberrant staining, like something weird about the stain. I could potentially repeat this one too, just to make sure it's for real. Or there are some plasmacytomas, plasma cell tumors, I should say probably more likely plasma cell tumors, multiple myeloma type situations that have had aberrant expression of CD3 in the neoplastic cells. And that is also a possibility in this case. But given that the vast majority were negative for CD3 and positive for MUM1, plus the morphologic features, the plasmacytoid morphology and the frequent multinucleate cells, this is myeloma-related disease, plasma cell tumor, something along those lines. And because of the sort of multifocal distribution and carpeting intraocular surfaces, strongly suggestive of a tumor that arrived at the eye from some other site. So good to check out the cat for something else going on in the body.
Kelsey, Rachel, the other KB,
Oh yeah.
so asking here on the chat if is it normal for our CD3 to be more cytoplasmic than membranous latent? And also, just so that people don't think they're going crazy, this is red chromogen as opposed to the.
Yes, the MUM1 was a brown chromogen.
This one, it's not like a PAS gone crazy.
Indeed.
So the answer is yeah, we usually see CD3 in cases of more malignant transformation. It does, shift from cytoplasmic to membranous to ultimately perinuclear when its expression pattern. The shuttling is not effective in transporting it to the surface anymore.
Do you guys hear?
Yeah. Did everybody hear
Dr.
that?
Gasper's answer? They're not. Just say
Okay.
Megan.
So essentially with malignant cells, we can see cytoplasmic expression. The shuttling of the CD3 to the surface of the cell is not as effective anymore. So you can get some cytoplasmic expression. I would also add that our red chromogen can kind of be a little bit more hazy than the brown chromogen, but it's nicer in your ocular tissues because there's often so much melanin sprinkled about in the eyes. I would say that there's probably some that are a little bit more membranous or perimembranous, and many though that are quite cytoplasmic.
Saying that we've gone quiet again.
What? Oh, we have?
Real quiet just now.
Oh. Okay.
All right, we'll try to deal with it.
Speak louder.
I will speak up from the diaphragm. So that was the
It's not what I wanted.
hello. Oh, okay.
All right, is it better now or? We're,
Maybe it's been kind of intermittent.
yep,
Okay.
yep, yes. yes, yes.
Interesting.
You're back.
Um,
We're back.
Sorry about that.
Can I ask the potentially problematic question of why you call it carpeting?
Good.
I
I
mean,
thought
it is
carpeting
kind
is-
of loosely associated with surfaces rather than necessarily like attached to the surfaces. So I would buy that carpeting is probably an inappropriate term there. I think that's
Also,
fair.
just, I don't think it's really well defined, but it seems like it's used more for like metastatic carcinomas. And so like having a round cell tumor described as carpeting is kind of, I mean, I've never seen any other type of sarcoma or.
Yeah, I think
We've
I
seen
tend
it in the
to.
eye, where
Yeah.
it's on the very surface. It's mainly saying, it's mainly on the ocular surfaces rather than from the stroma into the surface.
What were you gonna say, Megan?
I think that we use the term carpeting most frequently for carcinomas, often metastatic carcinomas, and also for asymmetric or asynchronous uveitis, which involves carpeting of epithelioid macrophages.
Mhm.
And so yeah, usually when the cells are kind of like tightly adhered in multiple layers to the surfaces. So I can appreciate your point there. But basically, when I'm using it here, I'm just trying to refer to how the cells, there are many that are sort of free floating in the ocular chambers, but many are also kind of clustered very loosely and in a kind of discohesive fashion along surfaces. So sort of along the epichoroidal surface and the retina there in particular.
We also have macrophages that carpet surfaces.
Yeah. So
Okay. Well, epithelial,
maybe
right, which kind of makes your point.
gathering along
If you're looking-
surfaces,
This is
perhaps.
Coplow, like.
We say what we want.
And if you're not happy, feel free. I'm joking.
The point is well made.
But I think it's more in terms of it's a descriptive term. It's not diagnostic term. So more subjective, imaginative.
Yeah. Maybe it might be better to say in this case that the multifocal and kind of extensive distribution inside the eye is suggestive of metastatic disease in this case, rather than specific.
Cool,
carpeting.
because,
Yeah.
yeah, like if they're metastatic, like, the whole like seed and soil hypothesis, and like, and then if they're in the ocular chamber where there's only one place for them to seed to, like,
Yeah.
or, how do they continue or make that kind of pattern reliably? Because it
Yeah.
does seem like it is pretty reliable. Static disease.
This is a good
Yeah,
question.
Yeah,
There are other patterns that we could use for metastatic disease, for example, multifocal vascular distribution.
mhm,
Especially in the back of the eye where we have the choroid capillaries rather than the RPE cells, you can have multifocal or more diffuse choroid capillaries infiltration. Plus or minus the covering carpeting
And
of
also
ocular
Covering.
surfaces.
the adhesion molecule distribution within the globe is really poorly characterized, and
yeah.
there is some evidence out there that there is differential adhesion molecule expression, retina versus uvea, et cetera. So.
Cool.
Affected.
The point is that there's some evidence that there's different adhesion molecule expression in the retina versus uvea, so there may be some incompletely characterized reasons why cells cluster in the eye the way they do, basically. Maybe clustering along surfaces.
Let's go on.
Okay, we'll do the next one. Here we go.
Sorry.
No, you should ask these questions. These are
Yeah,
these
no.
are interesting
Problem
discussions.
at all.
No apologies needed. So okay, the next case, which is actually very apropos, given Jamie's second case. So wait, we're gonna actually do the gross and the history first. So this is a 12-year-old pony gelding. So we have a horse. This is the left eye, which, let's see, there's lots of descriptions of normals, and then the abnormal, a pink tan raised mass, suspect a certain diagnosis, which I will withhold for a second, expanding and invading the 3/4 of the cornea, The anterior chamber is formed and clear. Pretty much everything else in the eye is described as normal clinically. Corneal mass. So we have the front and undissected view of the eye here on the left, and then the hemisected view on the right. And you can see this markedly thickened and opaque tan cornea, just as they said in their description. Also in this case, I'm going to point out back here in the fundus, there is this kind of unusual, almost wavy pigmented line back here, or sort of patchy pigmentation in the fundus, which is a little unusual, and we'll revisit that in a second. Okay, actually, let's see if we can do a subgross for this one. Ah. So here's the front of our horse eye. Ah, and there it went. So here is our corneal mass. It's definitely pretty cellular, mostly in the stroma itself. And I guess that's all we're going to show you on subgross. Let's just go straight to the rest of it. All right, cornea's to our right this time, because apparently that's my habit and I never realized until recently. But anyway, so we have this neoplastic population mostly infiltrating the corneal stroma and thickening the stroma itself. It's not actually forming much of an exophytic mass above the ocular surface. And if we look closer at who these cells are, they are little lobules and anastomosing cords of epithelial cells against a fairly desmoplastic looking stroma. Lots of reactive spindle cells in that stroma. Here we go. And many of these lobules of neoplastic cells are keratinizing towards their middle, essentially forming keratin pearls or discohesive keratinized cells in the centers. Brightly eosinophilic, lots of cytoplasm. So long story short, we have a squamous cell carcinoma, which was their differential. So histology supports their clinical interpretation, which is always nice. And the interesting thing about this squamous cell carcinoma in this horse in particular is that it is mostly in the stroma the way it is and not forming much of an exophytic mass. And so this is a type of squamous cell carcinoma in the cornea of horses that we refer to as a corneal stromal invasive squamous cell carcinoma. Basically just calling it like it is. It's mostly a invading the stroma kind of a tumor. And the reason why this is an interesting variant of squamous cell carcinoma in horses in particular is that grossly and histologically, you may have another differential for this cornea. And I can ask the room and be quiet this time, maybe. What might be another differential for a thickened and opaque cornea in a horse?
Fungal granuloma?
Nice, fungal. Yeah, so mycotic keratitis would be a common differential for this clinical and gross presentation. So both clinically and grossly, these eyes may often have a differential of mycotic keratitis, and then we find out that it's neoplasia. Some of these cases even arrive with a history of being treated as mycotic keratitis, and they were not responding well to antifungal treatment, as you might expect.
Or immune-mediated keratitis.
Or that's a good point. Or immune-mediated keratitis, confusingly abbreviated as IMMK. I guess we include the M from the immune. But
said eosinophilic keratitis is a different too. I guess.
Eosinophilic keratitis, that's a good one too. Yeah. Actually, eosinophilic keratitis was a differential for that cat we just looked at too.
Right.
So that's all very interesting, but wait, there's more. We had the interesting fundus stuff going on at the gross. Before I move back there, though, I'll keep you in suspense a tiny bit longer. There is the slightest cataract in this lens. A little bit of liquefaction of lens protein here. You can mostly see it based on the difference between this more homogeneous pooled area here, and then a little bit more of like a fiber, or the fiber structure is still present there. And maybe some migration of the lens epithelium or so. So a really subtle cataract, not much going on, but it is there. And then let's go back to the fundus. And from low magnification, we can see that there are these unusual pigmented spots in the retina. Here's one. Actually, there's another one right next to it that's kind of subtle. And another one here. And these spots are mostly in the ventral retina, although I'll show you another one in the dorsal retina in a hot second. We'll look at the best one here. And this pigmented spot is associated with outer to full thickness retinal atrophy, focally or multifocally, basically. We don't really have many of the recognizable layers of retina where all these pigmented cells are. And right adjacent to it, where it would have been theoretically attached, we have a hypertrophied looking RPE. So maybe a little tiny focus of retinal detachment and atrophy here. It's looking pretty similar at the site adjacent. And then we'll skip over to the, so way over here, also in the dorsal and very peripheral retina. We have a more normal retina over here, and then as we walk in this direction, outer to full thickness atrophy. And actually right here at this site, not only is there outer atrophy of the neurosensory retina, but the retinal pigment epithelial cells in this area are lost. So we have some unusual multifocal retinal changes in this case, with pigmented cells kind of diving into the retina itself. And then as I'm looking at this fundus, another thing that was a little unusual, let's head back, making everybody slightly nauseated here, hang on. Let's head back to the optic nerve, there it is. It was a long way away, as it would be in a horse. So this is the ventral side of the eye. And we can see that the RPE cells are pigmented. If we walk across to the dorsal side, the RPE cells are still pigmented, which is kind of unusual because this was supposed to be a dorsal-ventral cut. It's a little bit of a lighter pigmentation on this side. So I was curious, given that we have some pigmentary abnormalities in the back of this horse's eye, and did a PAS stain to query what this light brown pigment, especially noticeable in the dorsal RPE, might be. And it's not particularly convincing, but I'll show it to you anyway.
The job now is to convince us.
I know. Are you convinced that there is a little bit of pink in these RPE cells right here? What do you think? Keep looking and find another area.
Yeah, dial your imaginoscope up to.
Yeah, 9,000. Yeah, exactly.
No, I see it.
Yeah. Like it's there.
Here, for example, very subtle PAS positivity with respect to this stuff in the RPE cells. So a PAS positive pigment that's kind of brown on H&E, I'm suspicious of lipofuscin. The thing is, a little bit of lipofuscin accumulating in the RPE cells is not a big deal. Lipofuscin is a wear and tear pigment in cells. Any kind of aging cell can accumulate a little bit. We see it in the RPE not uncommonly. So it may just be totally a non-thing to find it here in the RPE. The reason why I was particularly hunting for it, though, in this case, is pigmentary changes in the fundus of a horse have been associated with lipofuscinosis and basically vitamin E conditions, low vitamin E in horses. So there isn't really strong evidence to support that that's what's going on with this horse's fundus, but suggested that they check the horse's vitamin E status in any case and maybe diet. And then other than that, it's basically a finding of unknown cause and significance, this multifocal retinal atrophy with pigment diving into the retina. It's been seen in quite a few older horses in the Coplow collection. It could have just been old sort of multifocal retinal attachments or old multifocal areas of ischemic injury of the retina. There's kind of a couple of different potential causes, and maybe still worth something worth still investigating a little closer. But just kind of an interesting extra in that horse with a much more important lesion up front.
Let's go back to the gross. Dr. D saying there was only a tiny tapetum in the gross image.
Yeah, it may be that it's just kind of a weird section.
Okay.
But I mean, yeah, there's a corpora nigra on one side and not on the other, and it's supposed to be a DV section. So.
Cool.
Yeah.
Yeah. Mini tapetum there on top.
Yeah. Oh yeah, right there. All right. So the main diagnosis, corneal stromal invasive squamous cell carcinoma. And some interesting things in the back of the eye as well. All right, I will shift. That is my last case. we're going to hear from Dr. Leandro Teixeira next.
All right, I have, let's see, looks like we got 10 minutes, maybe do one case. Hopefully two, but don't hold your breath. Speaking of horses, another horse, as you can see over there, that's a representative picture. We don't have a gross image of this case, but this one is a Tennessee Walker horse, 21 years of age. Let's see. The owner reported the left eye has been diagnosed with ERU, equine recurrent uveitis. Well, both eyes actually, but the left is more affected more than a year ago. And the left developed glaucoma, and they sent it to us. Another interesting thing was the fact that there was marked corneal edema. Blah, blah, blah. When I say blah, 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 it's usually I'm reading drug names. They did some stuff and put some drops on it. Okay, so here is a, as I said, a representative image. The lens looks luxated. You gotta be careful that, especially with horse eyes. They're very big, and when we're cutting, it's very easy to hit the lens, and the lens will just spin around. That said, the cool thing about this one is that since the lens is to the side, you can see on the surface of the ciliary body a wider, oh yeah, Lorelai is not here, so a carpet of white material. Yeah, I was gonna, just joking. And on the surface of the ciliary body, here's the tapetum right there, since we're talking about tapetum. Well, I was gonna say that's optic nerve, but it could be just the light passing through the lens and being focused on a very weird location. I think the optic nerve is probably right there, right? So mainly a gross image for the ciliary body surface. Now let's get back to histology. Again, big eye, so bear with me. If you guys don't puke today, you graduated from it after having 2 horses in a row. It's very unlikely that you would do so another time. All right, so here's the anterior segment of the eye. There's a lot of artifact which we have to take into account. There's some folding of the cornea. This separation of the iris leaflets are not real. Here's the lens. Then we have moving back to the ciliary body. Optic nerve is cupped, as you guys can see, and you can see a little bit of the retina coming off of it. So potentially a retinal detachment. We did the Swiss roll technique in this case, where we kind of cut the eye a little bit to the side and we roll it in a little bit so it can fit in the cassette. So this should be connecting right there. So you can mentally Photoshop it back in place. Okay, so let's see what we got. Starting from the cornea, we are at the limbus. See some pigmentation of the junction between the corneal epithelium and conjunctival epithelium. There's marked vascularization of the stroma. Pay attention on the thickness of the epithelium. It's kind of variable. There are areas of hyperplasia and keratinization. And also, right here, you can see there is a markedly difference in nature and tincture of the corneal stroma, mainly the mid to deep corneal stroma from the surface or the superficial corneal stroma. So this denser or eosinophilic area, these are all areas of corneal stromal fibroplasia. People will call that fibrosis. I have no problems with fibrosis because I think just communication-wise, but the corneal stroma is collagen to begin with. So fibrosis of collagen is kind of a hard thing to wrap around your mind because it's already collagen. So fibroplasia, meaning a different type of collagen is being deposited on the very surface along with the vessel. So let me just go higher magnification, show you that right away, and we'll be done with it. Guys, see the difference? You can see the lamellae of the deep corneal stroma, right? This is very important for the cornea because the arrangement of the lamellae maintain the corneal transparency. And if you lose that, you got denser, more haphazardly arranged collagen that will cause a corneal opacity, right? And then you have vascularization and inflammatory cells. The cool thing, we get right next to it, something happening here. This is Descemet's membrane. It's a 21-year-old horse. So Descemet's membrane gets thicker with age, and you can see how thick this is. And all of a sudden, there's this very sharp defect. We often have to try to differentiate artifactual breaks in Descemet's membrane from real breaks. And here, the reason I think this is real is because you have some reaction around that area, and there is a newly deposited thinner Descemet or poorly organized Descemet membrane-like material kind of spanning the defect. It gets better as we move on. And then here we go, and then the original one comes back again. That might be too close because it's an enormous horse. Another interesting point, again, this needs to be differentiated from artifact, how Descemet membrane kind of folds away from the corneal stroma. And so theoretically, all that portion, or all that deep corneal stroma is exposed to the aqueous, right? So we know that the cornea, in order to maintain its transparency, the corneal stroma is at a dehydrated state, right? Once you have a break like that, and the stroma, you know, I jokingly call it, it's like you guys remember one of those chamois towels? Like you put it on a bucket and the water disappears. So the corneal stroma is basically like that. So if you have a rupture in Descemet's membrane, the stroma gets exposed to aqueous and then just absorbs all that water, and then you end up with extensive corneal edema. So here's another large break in Descemet's membrane. And the separation in Descemet's membrane is a little hard to interpret. We think it's real just because of the way this usually works. But it will be really hard to prove that that's not just artifact. And there's another larger break in here. So this is a great example of the original Descemet's membrane. There's a break, and the corneal endothelial cells will proliferate and try to deposit a newly smaller one on top, right? So all that, sorry about not managing the microscope well there. All that suggests that those breaks are real. There are many, like 6, 7, 8, another one now. There's a baby one here, a baby break, maybe habstria, right? So you can imagine we're cutting this in one cross section, right? But if you look and put it back in a three-dimensional aspect, you will see linear breaks throughout the cornea. So if you're looking at it clinically, you will see more like fractures of Descemet's membrane. Right, Descemet's membrane has a little bit of elasticity, but it reaches a point where it just breaks. It's like, you know, when they're related to glaucoma, we call them habstria. It's like stretch marks on the skin. It's basically stretch marks on the on Descemet's membrane. Right. So now we know why the corneal edema. So there are multifocal breaks and separation of Descemet's membrane. It could be related to the glaucoma. It could be related to trauma. Right, we often associate that with trauma, blunt trauma. Another lesion. Okay, so don't have time to get into iridocorneal angles of horses, and I'm actually glad about it. So they look weird. They usually have this very thick pectinal ligament, right? And you want to make something out of it, like this is abnormal, but we see that in normal horses. We see that in non-glaucomatous horses. So that's unlikely to be the cause of the glaucoma here. Another thing I wanted to show before we move on is the ciliary body. So you guys remember on that picture that there was that white material over the ciliary body surface? This is not the best example of it, but again, let's turn our imaginoscopes on. There was a diagnosis of equine recurrent uveitis, and often what we see is accumulation of amyloid on the surface of the ciliary body. Again, not the best example, but it might be a little bit of amyloid material there. I'm not very convinced myself. Oh, that's better. right here. So some amyloid as a non-specific inflammatory response in these eyes. Another thing that we often see is what we call Cooley bodies. And again, speaking of Coplowisms, Cooley bodies are these linear intracytoplasmic inclusion bodies. These are probably non-specific immune-related crystalline material that accumulate on the cytoplasm of the pigment of the non-pigmented epithelial cells. Again, this is not the best example of it. And if you Google Cooley bodies, you will probably be redirected to a Coplow PowerPoint or something like that. The funny thing is, everybody in the world knows them as Cooley bodies, but they were named after someone that was visiting the lab that was working with ERU in horses, and was Dr. Penny Cooley. So it was a nickname that caught up, and I've seen people present in national meetings. And here you can see the Cooley bodies, and so don't try to Google that. So linear intracytoplasmic inclusions, those are characteristics of, or are characteristic of, as far as we know, equine recurrent uveitis, right? So in this case, we do have two things happening at the same time. We have the corneal disease, well, maybe three, right? Because go back to that optic nerve, it was markedly cupped and atrophied, so there was also glaucoma. There are other things happening here, but we're just going to leave it at that. So what's the potential sequence of events? There are many ways to skin this cat or this horse, but you can have the equine recurrent uveitis, the multiple inflammatory bouts leading to a secondary glaucoma. Then there's glaucoma, there's ophthalmos, the eye increases in size, got those ruptures of Descemet's membrane and separation and marked corneal edema, right? Another point could be that all that happened and there was a blunt trauma, because it's a horse, right? Blunt trauma to the eye at some point that caused a larger break in Descemet's membrane with the edema. So multiple ways you can go about this. In some cases that we have breaks and separation in Descemet's membrane, we've seen glaucoma without any other more obvious secondary lesions. And we believe that if you have a large enough fragment of Descemet's membrane kind of floating about, it could kind of work as a valve and block the pupillary margin and cause glaucoma. So many ways to go about this, but the main things are there. So ERU, diffuse Descemet's membrane detachment to corneal stroma, amyloidosis, interepithelial inclusions with equine recurrent uveitis, corneal detachment and tear. That cornea was really the complete retinal detachment and tear. That retina was really torn, which is another thing that might point towards trauma, and the secondary glaucoma. Does that make sense? All right, so thanks for you guys that came in person and for everyone there online, and I'll see you guys in 2 weeks.